grand round for tonight, and it's a very timely topic on health equity, discrimination, and anti-Semitism in medicine, given by Dr. Jackie Benayoun, who is a recent graduate of Suny Downstate College of Medicine in Brooklyn, who's about to begin her residency in pediatrics at Westchester Medical Center this summer. So mazel tov. She received a bachelor's degree in biochemistry at Yeshiva University and worked as a clinical research coordinator in the adult oncology department at Columbia University Medical Center during her gap year. Dr. Benayoun is passionate about community advocacy, mentoring the next generation of female physicians, and was involved in the bioethics and medical education pathways while at Downstate. The event tonight is sponsored by Dr. Hindi Mermelstein in honor of her daughter who just graduated from medical school, Dr. Tamar Dechko. Mazel tov, and all the newly minted JOMA physicians, Dr. Miriam Andruzier, Dr. Jackie Benayoun, Dr. Eliana Feinfeld, Dr. Panina Gross-Richmond, Dr. Molly Hagler, and Dr. Tamar Seidman. Huge congratulations. Mazel tov to you all. We're so proud of you. And just a housekeeping note, if you have any questions as you're hearing the talk, you can save them for the end, or you could put them in the Q&A chat box as we're going along, and I'll be monitoring the chat box and we can go through the questions at the end. Thanks.
All right, thank you for that introduction. I'm just going to go ahead and screen share my slides. All right. Just making sure they're visible. Yeah, okay, great.
They look great.
Okay, great. So welcome everyone, thank you for coming. We're going to be talking about health equity, discrimination, and anti-Semitism in medicine. And as Dr. Weinstock described, this was very much inspired by some recent events and just important topics that come up in healthcare all the time, and really things that we as physicians and healthcare professionals are going to encounter throughout all levels of our training. So just in terms of my disclosures, I am employed by the Division of Health Equity, the Department of OBGYN at SUNY Downstate. And here's our link, but otherwise nothing else to disclose. Okay, so going forward, just to mention some of the learning objectives for tonight, we're going to be demonstrating the relationship between health equity, discrimination, and anti-Semitism in medicine. We're going to explain the role of health equity in identifying areas of intervention that improve patient experience. We'll describe the impact of racism and discrimination on patient outcomes and how it can be prevented. And we'll analyze the history of anti-Semitism and its consequences on the healthcare professional to patient relationship. Okay, so first to begin talking a little bit about health equity. So what is health equity? I'm sure many of us have heard this term kind of used before, but how do we really define it? So the WHO, the World Health Organization, describes it as the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. So why do we really care about this topic? What's important about health equity? So life expectancy and healthy life expectancy have increased worldwide, but they've increased unequally globally. So there are these long-standing and widening gaps between those with the best and the worst health in the world and their well-being. So just to go into a little bit more detail, I'll show some graphs in just a second, but across the board, poor populations tend to experience worse health and health outcomes than richer populations. So just seeing this before we go into the graphical depiction. So looking at this, we see that there's a difference, according to the WHO, there's a difference of 18 years of life expectancy between high and low income countries. I actually was just on the WHO website today, and it actually stated that there's a 19-year life expectancy difference. So it seems like it has been updated more recently between, the highest income and the lowest income countries. In 2016, the majority of the 15 million premature deaths due to non-communicable diseases occurred in low and middle income countries. Relative gaps in countries between poor and richer subgroups for diseases like cancer have also increased in all regions worldwide. The under 5-year-old mortality rate is more than 8 times higher in Africa than in developed countries in Europe. And more about the child health, improvements in child health between the poorest and the richest subgroups have been impaired by slower improvements for the poorest subgroups. So even though overall, globally, we're kind of seeing improvements in child health like everywhere in the world, there's still a major lag for the poor subgroups. So looking at the health life expectancy, also called HALE, at birth years by country. So this is just a snapshot of a bunch of countries throughout the world and divided basically by continent or by region. So if we're looking at the average number of years that a person can expect to live in full health by taking into account their years lived in less than full health due to any disease or injury, we can see very clearly that in Africa, the average health life expectancy at birth is significantly lower than it is in other parts of the world, like in Europe. So in Africa, we're looking at least on my screen, it looks like around age of 66, maybe 67. But if you look at Europe, we're talking into like the early 70s. So there's definitely a very big difference in range. And obviously this all varies by country, and this is just a small synopsis, but this is important to understand globally how health equity impacts the world we live in. So looking at another similar type of graph, this time looking at life expectancy at age 60 years by country. And again, this is for both genders. We kind of see a similar discrepancy when we look at Africa and we look at the Americas and other parts of the world, Europe, et cetera. Okay, so to understand health equity, we kind of have to understand the social determinants of health. And I know that as a medical student, I had some classes on this topic. I had definitely training sessions, entire aspects of our curricular were devoted just to this term, but really to understand what it means, I found this great definition by the CDC. So social determinants of health are life-enhancing resources like food supply, housing, economic and social relationships, transportation, education, healthcare, whose distribution across populations determines the length and the quality of life. So we already talked about life expectancy, and we're going to actually delve a little bit more into quality of life throughout the presentation, but it really goes hand in hand. It's really how is a person expected to live, how long, and is it going to be healthy living for them based off of some of these factors that influence. So social determinants of health are the non-medical factors, like we said, that influence health outcomes. They're basically conditions in which people are born into, they grow up in, they work in, they live in, they age in often, and they're bigger forces at play that kind of shape the conditions of our lives on a daily basis. And they include everything from economic policies and systems, social norms, social policies, political systems, and really kind of extend throughout everything from education to working life conditions. You know, are you working in a mine underground, a coal mine, or are you working in an office job? Are you experiencing structural conflict just below? Is there a war in your home country? Are you living in a peaceful time? Things like that. And, you know, even within the same country and even within the same city, these factors vary significantly for different sectors of the population. What's interesting to know is that SDH, social determinants of health, is considered to be really, really important, and in many cases more important than actual healthcare or lifestyle choices. So, you know, like the famous saying, an apple a day keeps the doctor away. So, right, there are certain lifestyle habits that can influence our overall health, but is that really in and of itself what affects quality of life and what determines a person's life expectancy? Social determinants of health can account for up to 55% of health outcomes, which is a large number. It's not something, you know, it's almost half of health outcomes can just be understood even before the patient reaches the doctor's office or the hospital. The contribution of sectors outside health to population health outcomes exceeds the contribution from the health sector. And addressing these factors is key in improving health and requires actions from all aspects of society, but certainly as healthcare professionals, this is something that we are uniquely able to hone in on. So here's another pictorial from the WHO, which I thought was useful, even though it doesn't really talk so much about child mortality. It is child mortality in other parts of the world, but just looking at it, we see that in low and middle income countries, there are many factors that influence and are statistically significant in how they influence child life expectancy or child mortality. So everything from, health systems, do children have access to immunizations like measles and vaccinations? And obviously we're seeing this right now with the COVID pandemic, and we'll get into that very shortly. But, how about women's political and socioeconomic participation in the world? Level of education, for females especially, environmental management, do they have access to clean water, et cetera. Many of these are things that we look at globally, but again, in the US, we're not necessarily struggling with all of these same issues. Many children do have access to immunizations, but at the same time, we'll see shortly that there isn't always an equal distribution, even in first world countries. So some of the considerations we have to look at is that inequities in health are socially determined, preventing poor people from moving up and making the most of their potential. And really pursuing health equity means we're striving for the highest possible standard of health for all people. Yet at the same time, we're still giving special attention to the needs of those that are at greatest risk for poor health based on their social condition. So action requires not only equitable access to healthcare, but means working outside of the healthcare system to kind of help with social well-being and development in a more broad scale. So looking at this a little bit more, there are ways to take action. There are 3 areas identified by the Global Commission on Social Determinants of Health, just to see how can we incorporate change. So improving daily living conditions, and these are still broad categories, but just, we'll break it down further soon. So that's circumstances in which people are born into, grow, live, work, age, tackling inequitable distribution of power, money, and resources. For example, economic and urbanization policies and governance, measuring and understanding the problem and assessing the impact of action, developing a workforce that is trained, raising public awareness, and systemic action to make sure that we're accurately addressing some of these discrepancies, while also looking at the fact that there is disproportionate disadvantage. Okay, so health equity in the US, talked a little bit about it globally. So the National Association of County and City Health Officials gave a statement about some of the health equity differences in the US. So we know that poverty, income, and wealth inequality, poor quality of life, racism, sex discrimination, etc., all are major factors for ill health and health inequalities. Things like polluted environments, inadequate housing, lack of educational employment opportunities are all implicated in producing inequitable health outcomes. So these systemic, avoidable, that's the key word, avoidable disadvantages are interconnected, cumulative, intergenerational, and associated with lower capacity for full participation in society, and ultimately cost society greatly, including because there are threats to economic development, democracy, and the social health of the nation. So different organizations, governing organizations, kind of given us the tools we need as healthcare professionals to work toward achieving health equity. One of those is the healthypeople.gov group, which was first launched in the 90s by the US Department of Health and Human Services. It provides these science-based 10-year plans or objectives for the entire nation to kind of meet a standard of health. The CDC also publishes their Bulletin on Health Equity. And then I recently discovered that the AMA, the American Medical Association, has this really interesting prioritizing equity video series, which is a great resource for physicians if you're an AMA member. All right, so this is kind of a summary of what I just went through, the different groups, and I apologize if the fonting isn't so clear, but just to go a little bit forward. So the US Preventative Task Force also gives their recommendations addressing the social determinants of health. So they break it up into these categories. They have recommendations and screening for drug use, alcohol use, tobacco use, violence and abuse, everything from like elder abuse to intimate partner violence. They talk about malnutrition for kids, behavioral counseling, related to like diet and exercise, for cardiovascular disease, screening for obesity. I don't think I mentioned this, but also the depression, which is here, screening for depression in adults, children, etc. So there's definitely measurable ways that healthcare professionals can, in office or even before the patient reaches the office, completing a quick survey, asking the patient these questions, screening for these types of diseases. These are all ways of addressing social determinants of health, and they don't have to wait until somebody is in the emergency room to be able to get this information. This can all be done prior to entering an emergency situation. So just moving forward, I do want to talk a little bit about contemporary events. So with COVID, there's definitely been a lot of new light has been shed into the extent, I would say, of racial and ethnic disparities. So this study was put out by JAMA, the Journal of the AMA, and it actually looked at my hometown, New York City. So it looked at a cohort study of patients in New York City. And what they found was that Black and Hispanic patients were more likely than their Asian and white counterparts to test positive for COVID-19. Once they were hospitalized, however, what's interesting is that Black patients were less likely than white patients to have critical illness or die after adjustment for comorbidities and neighborhood characteristics. So Black patients and Hispanic patients were more likely to test positive, but they didn't have greater levels of critical illness or death. So what does this really tell us about the COVID pandemic? And what's been going on? And again, this is in New York City, but this really shows that there are existing structural determinants of health in the Black and Hispanic communities that can explain why there's disproportionately higher out of hospital deaths from COVID in these populations. So why in these regions and why in these specific racial groups we saw higher levels of COVID out of hospital than people actually getting treated. So that really, it's interesting because I think what it's showing us is that there must be things going on outside of the hospital that's impacting mortality rates. Okay, so similar finding in the UK. Sorry, I skipped one slide. Okay, here we go. So the British Medical Journal published some similar and interesting findings. They looked at the socioeconomic status and cardiovascular health in the COVID-19 pandemic. So this study specifically showed that people living in the most deprived areas of the UK were twice as likely to die from COVID-19 as those coming or living in the least deprived areas. So we can actually just look at the picture graph on my right-hand side. So if we're looking up here, cardiovascular comorbidity, we see that there's increased prevalence in certain communities, leading to acute cardiac disease or long-term cardiovascular morbidity. So in terms of COVID, some of these patients or people that were living in these deprived areas had a higher risk of exposure because either they were taking public transportation or they're living in multi-generational housing. And maybe they were more genetic predisposed for later sequela, but either way, it all impacted their development of the COVID infection, right? And they were already at greater risk for comorbidities. But on top of that, in terms of actually seeking help, medical help, they had certain barriers. For example, a language barrier, or their health literacy was lower. So these factors combined created a higher level of COVID viral myocarditis or other sequelae of COVID, possibly more critical care admissions or invasive mechanical ventilations. And just to circle back into kind of what we've been talking about, and we'll talk about in more detail soon, discrimination and other external factors also resulted or led to poor care, which kind of brought out more of the sequela. So this show is showing us that health disparities also extends the quality of the care that's received. Patients of African ethnicity have been displayed to receive delayed and lower quality care. And ethnic minorities sometimes experience barriers which prevent health-seeking behavior despite their desire to get medical attention. Those include, like I mentioned before, language barriers that prevent them from easily and quickly accessing care. And in the US, where we don't have universal healthcare system and not everyone is universally covered by insurance, we might even see greater disparities. So I saw something quoted that 23% of African Americans were less likely to be insured than white individuals, which was at 17%. So with those kinds of differences, you can see that there might be barriers to receiving care. And then looking at just a nice summary of what's been going on in the US with COVID, and just seeing that the inequalities in America have been exacerbated. So this study was performed in the Midwest in Indiana, and it examined pre-pandemic and during pandemic data from this population in Indiana, looked at factors like housing insecurity, food insecurity, financial insecurity, et cetera, and also looked at people based off of their educational disparity, so their level of high school, college, et cetera. And as we can see pretty easily, Black people and Latino people are often disproportionately affected by food and housing insecurity. And just for the asterisks, anything with 3 asterisks represents a probability of less than 0.001%. And similar findings for level of education. Individuals that had less than a high school education reported significantly higher rates of economic precarity across every outcome. Meanwhile, individuals with a high school diploma and some college tended to have economic precarity that falls between those with less than a high school education and those with a bachelor's degree. Okay, so moving on to discrimination in medicine. Let's talk a little bit about this. So racism and discrimination are ingrained into social, political, and economic structures of our society. And there are sometimes subconscious prejudices that exist. These are called implicit bias, and they affect the way we treat patients from diverse backgrounds. So just to understand implicit bias, again, this is something that we kind of learn, at least at my medical school, and as part of our curriculum, but just to refresh, or for those unfamiliar with the term, implicit bias in healthcare can shape the way that medical providers interact with patients. Everyone is kind of susceptible to implicit bias. It's like these unconscious perceptions that kind of seep into our communications with others, especially with patients. So looking at some of the effects that implicit bias can have in medicine, and this is from the Joint Commission, actual examples, non-white patients will receive fewer cardiovascular interventions and renal transplants. There's a higher mortality rate for Black women who are diagnosed with breast cancer. Non-white patients are less likely to be prescribed narcotic and non-narcotic medications to control pain. Black men are less likely to receive chemotherapy and radiation therapy for prostate cancer and more likely to have surgery. Black women diagnosed with endometrial cancer, although they're diagnosed at the same rate as their white counterparts, they have a 55% greater 5-year mortality rate than white women, partially caused by delays in diagnosis. And patients of color are more likely to be blamed for being too passive about their healthcare. So without even talking about the experience that patients undergo when there is this structure of implicit bias in medicine, just to see like facts on the ground, health outcomes, we see very, very alarming numbers. I thought that 55% was, to me, pretty alarming. All right, so historically, there have definitely been instances of discrimination and racism in medicine. And unfortunately to say, there's too many to include in a 1-hour presentation. So I did want to focus a little bit more on the 20th century, but this is probably one of the most, I would say, well-known, if I can, examples of discrimination in medicine in the past 100 years. So the Tuskegee experiment occurred in 1932. So the US Public Health Services engages the Tuskegee Institute in Alabama in a syphilis study. Around 600 Black men, 399 of them had syphilis, 201 didn't, were enrolled in the study. They didn't provide informed consent. Researchers told them that they're going to be treated for bad blood. This is a general term that was used to describe different diseases. Malaria kind of just encompassed a lot of hematologic or infectious conditions that lay people might not necessarily, that's how they would refer to it, but they don't necessarily know what diseases or infections it includes. And in exchange for taking part of the study, these men were provided with free medical exams, free meals, burial insurance, so there was incentive. In 1943, penicillin becomes the treatment of choice for syphilis, but the men in the study were not treated. In 1972 was so this is already close to 40 years after the original study. The first news article about the study was released. 1973, a class action lawsuit was filed, and it took up until 1997 that a US president formally apologized or condoned what happened in Tuskegee. Okay, so another example, this is one that really meant something to me because I really enjoyed reading the book about Henrietta Lacks, and I know that there's been a lot of attention, like a movie was made in the past 10 years or so, or 15 years, and I think it's just a fascinating example of how medicine was practiced in the past 100 years, and really how many of our principles of medical ethics and bioethics have developed because of such examples, unfortunately. So Henrietta Lacks was a woman who died in 1951 she was from Maryland, or at least that's where she lived, where she received her medical treatment. So she was a Black woman, and she had cancer, and the hospital where she was receiving treatment collected her cells. They were one of the few hospitals at that time that were providing medical care for Black people in that area. They collected her cells without her consent, and they used them to develop a cell genome line out of her cell line. None of the companies that profited from her cells gave money back to her family. For decades after her death, the doctors and scientists neglected to ask her family for consent, and Nature published the genome of another HeLa cell line after the Lacks family reached an agreement with NIH to approve its release. So it also took many years for the family to receive compensation and for there to be acknowledgement of this involuntary contribution that she made to medicine. So talking a little bit more about maternal mortality, and this is more directly correlated to the work that I've done at Suny Downstate, and I want to credit my friend and recent MD grad along with myself, Aladuni Agundupe. We've been studying maternal mortality over the past year, along with the rest of the Division of Health Equity at Suny Downstate, and trying to understand, how does maternal mortality in certain parts of the US, and specifically in New York City, and specifically in our subgroup of population, which primarily consists of Afro-Caribbean patients, how do we understand the mortality rates? So just looking at a little bit, also staggering numbers here, pregnant minority patients have been shown to have negative outcomes at higher rates than their non-minority counterparts. Nationally, Black women remain 3 to 4 times more likely to die from pregnancy-related causes than white women, and are more than twice as likely to experience severe maternal morbidity. 13.64% of babies born to non-Hispanic Black women are preterm, compared to 9% of babies born to non-Hispanic white women and 9.45% born to Hispanic women. And several studies have shown that perceived or self-reported discrimination have been associated with poor mental and physical health outcomes. So just talking a little bit about maternal experience, studies exploring maternal experience focused on a variety of outcome measures. including if there's been any sort of subtle or overt discrimination, and also patients' perceived abilities to participate in medical decision-making. So there was a study that was performed in US hospitals in 2011 to 2012, and it looked at the relationship between women declining procedures and discrimination during the childbirth hospitalization. So if they were likely to decline certain medical procedures, were they more likely to be discriminated against. So women who reported having declined care for themselves or their infant during the childbirth hospitalization were more likely to report having poor treatment based on their race and ethnicity, insurance, or any other difference of opinion with their healthcare provider. But in the context of childbirth care, women pay a penalty for exhibiting behavior that may be perceived as uncooperative. And we'll see that this penalty may be greater for Black women. So looking a little bit, not just in terms of the experience of the patient, but also the experience of healthcare professionals, because that is who we are addressing tonight. There has historically been instances of discrimination in medical training. And it really takes a lot of combing through to find exact numbers, but it's interesting to kind of learn the history of the medical school admissions process and how many non-white, and even I didn't even go into female versus male, but just looking at things like race alone to see how things have changed since the early 20th century, but definitely the late 19th century. So the late 19th century, non-whites were denied access to even basic medical care. Many medical facilities were white only, like white only hospitals. So in response, in 1868, we have Howard University opening up as the first medical school for minority doctors to train Black physicians. Howard faculty were denied membership in the AMA's Washington, D.C. branch. So in 1884, they formed the National Medical Association, which is an all-Black medical society. And by 1950, we have white medical schools graduated less than 15% of Black physicians. So it's still a very small percentage. And there are fewer than 100 Black specialists throughout the country. That's 1950, 70 years ago. All right, so today, the number of medical school applicants has increased significantly from 53%, increased by 53%, all the way up to like 50,000 applicants. I believe some of these numbers might even be like 5 years old, looking just ahead, 2002 to 2017. So I'm sure those numbers might have even increased since. But yeah, there's definitely a lot more matriculants in the past like 20 years. Meanwhile, Black, Hispanic, and all the subgroups of students from both sexes were underrepresented, and a significant trend toward decreased representation for Black female applicants. So we're still, basically what I want to say with this is we're still not where we need to be. We're still slowly climbing up, although these numbers are improving. But even just thinking a little bit about, you talked a lot about the experience of discrimination from the patient and even medical trainees. How about for a doctor or a nurse or any healthcare professional, is there ever discrimination bias centered toward them? So I did find some interesting reports, and some of them were blogs, some of them were published journals, but it's interesting to see that there have been plenty of medical professionals that have been on the receiving end of bias and racism. So one of them was this Dr. Sadi, who wrote about her experiences treating patients at her hospital. She had been questioned and attacked by patients because of her appearance, her religious belief, and the way that she dressed. We see the same type of thing with doctors of other sort of, religious or racial backgrounds. And there have actually been guidelines for doctors to deal with racist patients or just being discriminated by patients and their families. So that's an extremely difficult thing to grapple with, because we're always, taught to deal with professionalism and to have empathy toward our patients. But it's certainly hard when you're on the receiving end of such biases in the other direction, I guess we could say. So I just wanted to actually talk a little bit about, just as a matter of interest, medical calculators and how they incorporate race. So this might be a little more tangential, but there are medical calculators that incorporate race when doctors are making treatment-based decision plans. So one of them is for the VBAC calculator for the vaginal birth after cesarean to determine should is a woman a good candidate to do a trial of labor after cesarean section, or is a repeat C-section the best way to go for her. So some of the specific risk factors that are accounted for in this calculator are the patient's age, their BMI, how they had their prior deliveries, and race ethnicity. So there's a correction factor that actually subtracts for the likelihood of successful VBAC for any woman that identifies as African American or Hispanic. They're assigned a lower at baseline chance of having a successful VBAC compared to a white woman. So for example, if you have a 30-year-old woman who has a BMI of 35 and one C-section, because she's in arrested labor, she can have a 46% chance of successfully VBACing versus, an African-American woman or Hispanic woman with the same exact past medical history. She has it in the same BMI, she has a chance of 31%. So evidence suggests providers are influenced by their concerns over liability and perceived risk while they're counseling patients about a child labor after cesarean section. Now, it is critical to acknowledge that there are racial inequalities in maternal outcomes. We already acknowledged them before, but it's interesting to think if there's no biological plausibility for race-based correction, and if they can worsen existing disparities, do we want to continue to include these factors in our VBAC calculators? So that's just one example. And I saw a similar thing with the EGFR calculator. So calculating the estimated glomerular filtration rate, there is also a correction factor for race. And it raises into question if we're assessing for things like chronic kidney disease or other other conditions, are Black patients going to be underdiagnosed and undertreated because of this corrective factor? So just to move a little, I'll actually just mention the last bullet point. So if you remove race as a factor in recommending care, it's going to reclassify about 33% of Black patients to a more severe stage of CKD, which can actually really affect their management, how likely they are to be referred for a kidney transplant and a dialysis access planning. And I really got interested in this because I was watching one of the AMA health equity videos, and they talked about this specific kind of contemporary topic of EGFR calculators, and really just to see how some of the doctors anecdotally talked about their own experience or with their own family members, and their outcomes related to kidney disease and EGFR. So I thought this was very timely because it seems like it is a hot topic right now in medicine. So going back to, let's just circle back a little bit to implicit bias in healthcare. So we talked about implicit bias, referring to the attitudes or the stereotypes that affect our understanding, our actions, our decisions in an unconscious manner. They can include favorable and unfavorable assessments, and they're often involuntary. They're pervasive, they're subconscious, people are often unaware of their implicit biases. They can predict behavior, and it's not like everyone has the same level of implicit bias. Even people from the same cultural background, from the same family background, might have a different level of implicit bias. So how do we lower implicit bias when it comes to racial bias? How do we really, how do we tackle this issue? And this is not, again, just a 1 hour talk that's gonna fix and cure all, but at least to give us a little bit of guidelines. A joint commission, again, gives us a little breakdown. So there's perspective taking. So, when we think about the perspective of the patient, it helps reduce bias and inhibit our stereotypes and prejudices. it can effectively change the patient's level of satisfaction, their level of adherence. So that really changes health outcomes. Emotional regulation skills. I thought this was a really good one. Clinicians who have good emotional regulation skills and they experience positive emotion during their clinical encounters with their patients are more likely to look at patients based off of their individual attributes and be more likely to view them in an inclusive way. And partnership building skills, clinicians who create partnerships with patients are more likely to develop a sense that their partner is on the same team working toward a common goal. So it's really important to partner with our patients. So just to summarize this little bit on the discrimination medicine, and then we'll move on to anti-Semitism. So the USPSTF, again, gives recommendations on combating implicit bias. And we kind of reviewed some of these, but just to state them again, understand the cultures of the patients that are coming into your office, avoid stereotyping them, look at them as individuals, respect for yourself the magnitude of your own possible unconscious bias, recognize situations that might magnify stereotype or a bias. For example, if you read something in the news about a particular community, or if you had a patient last week from that specific community that did X, Y, or Z, you should know that maybe that's going to make you have a preconceived notion of the patient that's about to walk into the door. Performing teach back, just to make sure you and your patient are on the same page. Evidence-based medicine, always practicing it very, very closely. And, training, intergroup talks, perspective taking, all those things. Okay, so now our third topic, so anti-Semitism and medicine. And again, like I mentioned with discrimination, there's been a much longer history, unfortunately, of anti-Semitism in medicine than this talk allows for, but I definitely want to talk at least on the main points. So historically, there has been scapegoating of Jews that occurred during infectious disease outbreaks. And Jews were often stereotyped as vectors of disease. So in the 1300s, during the bubonic plague outbreak in Europe, countless numbers of Jews lost their lives in massacres throughout Europe. Jews were accused of causing the death of their Gentile neighbors by poisoning wells and other water sources. People didn't understand how the disease spread, so they accused Jews of poisoning the local water supply. Okay, so I am skipping a little bit to the US, and excuse me for moving around from topic to topic, but I did want to talk about something that impacts trainees, and then I'll talk more about the experience of individuals in the medical system. So anti-Semitism in medical training actually has a long history in Europe, but at least in the US, to talk about it within the past 100 years. There were quotas, and this was largely influenced by the World Wars, by World War I, World War II. So Jewish students and physicians were actually limited in terms of how many of them could attend graduate and postgraduate trainings. Jewish students were considered to be too studious or forceful in their desire to succeed. And therefore, many prestigious academic centers limited acceptance of these students. And this actually increased stereotypes on top of creating barriers in training, and also excluded Jewish students from entering other professional training, not just, medical school. Quotas were in place in the 1920s, and they were well entrenched by 1945. It wasn't until 1970 that a lot of these quotas were really removed. I think after World War II, that was when anti-Semitism was most pervasive in the US, and that's really when these quotas were more strictly enforced. So also just talk a little bit about discrimination in terms of Jewish physicians and Jewish work, bodies of work that were unduly credited, or that we saw in Germany and Europe, but there was also discrimination against these physicians. So uncredited work by Jewish physicians included work for myasthenia gravis. There were four physicians in Europe that collaborated together, were Jewish, and didn't receive credit for their advancements in neurology toward understanding of this disease. And there's also an extensive list of doctors that had contributed and even have a bunch of diseases or syndromes named after them that were persecuted during the Holocaust. So those include like Niemann-Pick disease, something I learned about in medical school, the Jerisch-Herxheimer reaction, etc. So going to the Holocaust, and again, I apologized in advance that I went a little bit out of order because the Holocaust is probably one of the most well-known and publicized examples of anti-Semitism in the healthcare system, not just in terms of anti-Semitism, but I would say also discrimination worldwide. There are some photos here of Jews, basically of Jews being experimented on, but here's a set of twins who are experimented by Dr. Joseph Mengele. Dr. Joseph Mengele was a German physician, also who was known by the moniker Angel of Death because he did very, very cruel experiments on Jewish and non-Jewish patients in the concentration camps, gypsy patients, etc. And people very much feared him because of the cruelness and the unethicalness of his twisted experiments. He particularly liked to experiment on twins. He thought they were more genetically interested, and he was fascinated by eugenics. And this was something that he liked to study. So as I mentioned before, Jewish patients in concentration camps were forcefully experimented on, whether it was being put underwater, exposed to freezing temperatures. They were exposed to infectious diseases because they were given different drugs to try to treat those diseases, forced sterilization. And like I mentioned, these twin studies. Other things that Joseph Mengele did on twins, he would amputate limbs that unnecessarily so intentionally infect one twin with typhus, and then transfuse the blood of one twin to the other. And many of his victims died just during the experimentation alone. And obviously none of these things were done with any sort of consent, with any sort of knowledge from the people being experimented on. Physicians during the Holocaust also assisted in the development of euthanasia and genocidal tools against patients, unfortunately. So I want to jump ahead a little bit to what's going on today, and also in the interest of time, try to give us a little bit of time to talk about how we can really use this knowledge to empower ourselves when we deal with patients, and how to avoid anti-Semitism today, and really understand how all this history of discrimination in Jewish medical literature kind of informs how patients come into the office and what their feelings are. So this is an op-ed about the COVID-19 written by a physician. He talks about how there's been a lot of anti-Semitism that resulted from the COVID pandemic. So anti-Semitic tropes that have emerged during this pandemic include the virus is fake and it's just a Jewish conspiracy. The virus is real, but it's still a Jewish conspiracy. Jews are the primary spreaders of the virus. The deaths of Jews from COVID-19 should be celebrated. And I thought this was particularly horrific. The coronavirus should be deliberately used to kill Jews. Anti-Semites dubbed this the Holocaust. So, you could see that even today, this is not something, anti-Semitism is not a thing of the past. It is very much present in the medical community, or medical disease or diseases are often blamed on specific subgroups of the population. So talking a little bit about, the Holocaust, since I mentioned it before, there is this concept of historical trauma narrative, and this applies to any form of discrimination against any minority population or population that has this history of not having used informed consent or having been experimented on. So when there are these situations where there are mass traumas or structural inequalities, a person might experience these perceived discriminations, microaggressions, and there's still this meaningfulness behind the historical trauma. So just moving forward, public and personal relevance, believability, and meaningfulness of historical trauma narratives. And ultimately, it's going to impact individual and community health. So just to break it down, the American Psychiatric Association has this really wonderful but somewhat long toolkit used to assess and help treatment for marginalized populations. This one is specifically for treating Jewish Americans, but there's wonderful tools on their website for treating any subgroup of minority patients, specifically using a stress and trauma toolkit. So this first slide applies to everyone. You take a comprehensive social, cultural, and religious history from all patients, asking questions on, do you identify with a specific religion or ethnicity? Does your family identify with one? How does your religion or culture offer solace in times of stress? Did you or your relatives seek asylum for religious or religious or political persecution? What holidays you observe? Questions like these. Even I thought this was very important, but again, this is from the American Psychiatric Association. When you're asking about suicidal ideation, and not to take light, but really it is a very important point, asking the patient what is the role that their religion plays in such plans. Like, what are their religious views on certain things related to suicidality or mental health? So, going even a little further, when you're screening and assessing for mental health disorders, like trauma, PTSD, depression, anxiety, it's important to become familiar with the person's background. Being Jewish is defined and experienced differently by different individuals, right? Some view it as a religion, some might identify it with it culturally. So, a person's attitudes towards different, even towards their nationality and nationalism might differ. Using terms like the Jewish race might be a little bit offensive, since that was a term that the Nazis used to identify Jews. And being aware that official and unofficial Jewish subgroups exist, they vary in observance, they vary in things like synagogue attendance, charity affiliations, dietary observances, Sabbath keeping rituals, dress codes. That's very much a community dependent thing. The patient's choice of dress, hair, hemline, all these things cannot in and of itself be a reliable signifier of religious affiliation, though it is something that is definitely okay to inquire about in a way that's going to allow you to partner better with the patient. Being aware that people who are observant or religious may engage in sexual practices that put them and their family at risk for undetected STIs, so never to make assumptions. Incorporating the strengths of patients in a treatment plan. So you can help empower a patient by recognizing their religious background. If you listen to the patient, you validate them, it really will help them. It improves the doctor-patient alliance overall. Encourage support from family members. And that, again, applies to all patients from all backgrounds. Incorporating religious or spiritual values of patients into a treatment plan when appropriate is definitely important. If appropriate for a particular patient, considering discussing how their traditions can combine with or reinforce contemporary techniques that support mental health, like prayer practices, meditation, etc. Psychoeducation about the potentially protective role of religion in mental health. If a Jewish American has a bad experience with other therapists or healthcare professionals who disregarded some of their religious beliefs, you can alert your patients to your own openness and your willingness to hear about their religion, in terms of acceptance and stuff like that. Talking to religious patients, including Jews, about how religion can provide strength in adherence to treatment and protect against suicide. And then finally, in terms of offering medication, and again, this is from the American Psychiatric Association, but this really can apply to providers from different fields in healthcare. Prescribing medication as needed and discussing medications during ritual fast, Passover restrictions, pork products and gelatin. This can apply to Muslim patients as well. So really just knowing dietary restrictions, from different religious subgroups, or asking your patient, again, not making assumptions. Even in capsules, there's gelatin. So that's an important thing to know if you're treating a Jewish patient that observes, a stricter level of kosher. And again, asking questions, avoiding assumptions. So just to kind of get to our take home point, because I'm about finished. So we've definitely improved vastly over the past century in terms of health equity. We've created a more global society, and that means that we're going to meet new types of people, and we're going to care for new kinds of patients every single day. So when we look at things with respect and humility, and understanding and validating other people's needs and their perspectives, it's going to help us as healthcare professionals really be the best physicians that we can be, and really just understanding that everything kind of interplays, right? A person's geographic location, their sexual orientation, their socioeconomic status, will affect their health promoting behaviors, which eventually can affect their community health and their individual health. And it's really not just one distinct factor. It's kind of like this whole complex web of aspects that influence a person's health. So these are my references. Special thank you to some of the people I worked with at Suny Downstate, and to some of the attendings that helped, Dr. Sanders from the Department of Psychiatry at Downstate, and Dr. Mira Hellman, one of the JOMA members who really reviewed my talk. Does anyone have any questions?
Thank you so much. I mean, that was just such a comprehensive, timely, and excellent review of these very, very important topics that we all need to keep in mind, certainly during our training, and you're about to embark on your residency, as are many of the listeners here. But, I think at all stages in your career, these things become very important. And I really think there's been an increased emphasis on these topics recently. I've certainly seen it. There's a lot of DEI work going on, which is diversity, equity, and inclusion. Certainly, this is something very interesting. I was asked to join the ACGME DEI Council, and I was asked to join as an Orthodox Jewish physician, not even as a woman, but I am happy they included a woman. There's two of us, a man and a woman. And I think there's a really big push to include a lot of voices in medicine and to make sure that our concerns are addressed. So I really was very heartened by that. And I'm hoping that, we can take that and really push for a lot of, inclusion and change in terms of Jewish and Orthodox concerns being heard in medicine. We did have one question come through, and that relates to, this is back to your slide about our doctors' targets. You talked about a study with Dr. Sadi, and there was a question about whether or not these concerns include osteopathic medical schools. I don't know if you know that, if there's any difference that's been shown in terms of training and sensitivity between MD and DO training.
So unfortunately, I can't answer to the MD versus DO, and I'm not even sure that most of the data that I found, both for looking at discrimination against minority groups like Black, Hispanic, and also looking at anti-Semitism and quotas, really differentiated. I mean, I saw the names of individual universities, which I know if they're accredited as an MD or a DO school, but I didn't really see that brought out. But in terms of, I think, what a doctor, a nurse, or a PA, or any sort of, again, any person working in a hospital, what they might experience when they go into their room. I mean, it's the same kind of thing. It's like we have our implicit biases, our patients have their implicit biases. And there's definitely this understanding that when somebody looks like you might more readily want them to treat you versus somebody else. But I think that just knowing that your patients have those like preconceived notions, quote unquote, really empowers you, because once you start opening up the conversation and you start asking them about their social habits in a very open, non-confrontational way, you ease it into the conversation. you develop rapport with the patient, I think that it's totally fair game for these perceptions to change. And I think that it is unfortunate when healthcare professionals are on the receiving end of discrimination, because at the end of the day, you know, we are protected in many ways, but we have to always maintain the highest level of medical integrity. I just got to say my Hippocratic oath just this week to treat everybody with equity and fairness.
Awesome.
Yeah, but it's a challenge. It is a challenge. You know, not every patient that we see is going to have done something that we might agree with. We might have seen a patient who performed a criminal act and then they end up in the ER. But at the end of the day, people are people. And I think that's why the emphasis is on looking at people individually in medicine.
Yeah, you're going to do great. I'm jealous of your patients and the hospital that gets to employ you. I think you're going to be a superstar. Just one thing I wanted to add, because you mentioned a lot about cancer disparities and higher mortality and breast cancer, et cetera. You know, I'm actually, I was looking into this topic recently because I'm giving a talk on disparities I'm a GU oncologist, and I was looking at like clinical trial enrollment, and, you know, Black patients are really, really very minimally represented. If you look at the representation, it's like 1% to 2% of trial patients are Black or African American, self-identifying. And so I was presenting my talk on this, and someone was like, well, what are the percentage of African American patients in the US who actually have bladder cancer? And I was like, you know what, that's a really good question. And the truth is, it's really not that high. It's not that much higher than 2%, 1% to 2% of patients, because overall the numbers of Black patients are lower. And then bladder cancer happens to be much more likely to happen you know, so some of the things that we think are egregious deficiencies on our part may have biological bases or, you know, different incidences in different populations. And so there are so many different factors that come into play. But I think if it's a topic that's on your mind and really at the forefront of how you care for your patients, then that's what we can ask for. That's the most we can ask for. And I really wish you all the success. This was just such a great talk and a great overview of the topic. And I have a comment from Dr. Pop. Thank you very much for I think the ACGME, I think that was it was very heartening for me to hear that was something that they wanted to include. I think hopefully we can all be ambassadors of this cause to our professional societies and everyone we come in contact with. So thank you so much. Great talk. And thank you for joining us, everyone who joined. And if there are any more questions that I didn't get to, you can always email us. Thanks. Have a great night.